Welcome to This Explainer. Today, we're going to act a little bit like artists. We'll be zooming in and zooming out to create a complete picture of the complex, occasionally messy, and honestly utterly fascinating world of gastrointestinal disorders. The gut is really one of the most dynamic systems in the human body. It acts as this incredible intersection of digestion, immunity, and even neurology. So today, we're going to explore exactly what happens when that complex machinery breaks down.
Okay, let's just dive right in with a statistic from global research that honestly blew my mind. Between 11 and 21%. That is the percentage of people worldwide suffering from just one of these disorders, irritable bowel syndrome, or IBS. I mean, think about that for a second. Up to one-fifth of the global population is navigating everyday life with chronic gut dysfunction. So this isn't just some niche medical anomaly. It's a massive, everyday reality for literally millions of people.
To make sense of this massive landscape, here's our roadmap to sketch things out today. We'll start with the big picture of GI, zoom into irritable bowel syndrome, contrast that with inflammatory bowel disease, tackle the danger of diarrhea, and then wrap up with diet, drugs, and solutions. All right, let's kick things off with section 1, the big picture of GI. Now, the burden of these diseases goes way beyond just the clinical symptoms of abdominal pain or altered bowel habits. We really need to ground this clinical data in real human experiences. GI disorders often mean missing work, avoiding social situations completely because of anxiety, and basically living a heavily impacted daily life. It's a systemic drain, and not just on healthcare resources, but on human potential and well-being.
Moving right along to section 2, let's zoom in on irritable bowel syndrome, or IBS.
So, the crucial point here is that IBS is typically what we call a functional diagnosis of exclusion. Because there isn't any visible damage to the tissue, clinicians have to rely on symptom patterns. And that's exactly where the Rome 3 criteria come into play. To get a diagnosis, a patient has to show a clear pattern of recurrent abdominal pain at least 3 days a month for the past 3 months. Notice how strictly these criteria tie the onset of pain to a change in bowel habits, either frequency or form. Oh, and note that the pain often actually improves with defecation. It's a highly specific pattern of dysfunction. Now, because IBS is a highly heterogeneous disorder, it is definitely not one size fits all. Based on those altered bowel habits we just talked about, patients are actively divided into distinct subtypes. You've got IBS-D for those who predominantly suffer from diarrhea, IBS-C for constipation, IBS-M where these features are mixed, and then a small subset that basically remains unclassified. Figuring out exactly which quadrant a patient falls into is absolutely crucial. It's the foundation for targeting their treatment. Let's switch gears a bit for section 3, inflammatory bowel disease, or IBD. Now, I know these acronyms sound practically identical, but physiologically, they're worlds apart. It helps to think of it kind of like this. IBS is a software glitch. It's a communication breakdown between the brain and the gut, but the physical hardware looks completely fine. IBD, on the other hand, is structural hardware damage. It's an organic disease. If a doctor performs an endoscopy on an IBD patient, they're going to see visible inflammatory destruction, swelling, and actual bleeding ulcers. And because IBD involves real tissue damage, the body reacts systemically. Patients experience some pretty alarming symptoms like rectal bleeding, unintentional weight loss, and systemic fevers paired with night sweats. The location of the pain can even act like a map for the clinician. Pain in the right lower quadrant often points toward Crohn's disease, whereas left lower quadrant pain is super common in ulcerative colitis. Okay, let's shift our focus to an acute issue in section 4, the danger of diarrhea. To really understand what's happening under the surface here, we have to look at the mechanical failures involved. First up is secretory diarrhea. This is essentially a pump that has just gone out of control. Bacterial toxins irritate the mucosal lining, and that stimulates the active transport of electrolytes straight into the small intestine. Water naturally follows those electrolytes, which leads to dangerously large watery volumes being aggressively pumped out of the body. And the wild part? This will persist even if the patient completely stops eating. Now, that sharply contrasts with osmotic diarrhea, which is an entirely different kind of physiological failure. Instead of the gut aggressively pumping out fluid, here the gut is failing to absorb nutrients. When unabsorbed solutes, like certain sugars, stay in the bowel, they basically act like a sponge. Through osmosis, they actively pull water out of the body and into the intestinal tract. So it's really a maldigestion issue rather than an active toxic secretion. And you know what's fascinating? Environmental factors add another layer of color to this clinical canvas. The timing of these acute pediatric infections is highly predictable. Bacterial infections, which often cause that secretory diarrhea we just talked about, they peak during the summer and rainy seasons due to environmental hygiene factors. In stark contrast, viral diarrhea, like the rotavirus, strikes hardest during the cold winter months.
Finally, let's zoom back out for Section 5, Diet, Drugs, and Solutions.
These days, modern digital tools are actively changing the landscape of functional disorders. Take something like the Low FODMAP diet app developed by researchers at Monash University. For conditions like IBS, where specific carbohydrates trigger symptoms, diet is absolutely a primary therapeutic tool. But managing it is super complex. Tools like this are a game changer because they empower patients to become active participants in their care. It allows them to safely track dietary triggers using a simple traffic light system, beautifully bridging the gap between clinical research and daily patient reality.
But beyond diet, clinical pharmacotherapy relies on highly targeted drugs where the treatment is entirely dictated by the underlying mechanism. For the inflammatory destruction we see in ulcerative colitis, we use agents like mesalamine or 6-MP to suppress the immune response. For chronic pancreatitis, where the organ is literally failing to produce digestive enzymes, we simply replace them with exogenous pancreatic enzymes so the patient can actually absorb their food. And for an acute upper GI bleed, we immediately suppress stomach acid with intravenous pantoprazole to stabilize the clot. The therapy has to precisely match the pathology.
As we finish painting this picture of gastrointestinal health today, I want to leave you with one final thought. We've mapped out the structural damage of IBD, and we've explored the functional misfires of IBS. But as our understanding of the brain-gut axis deepens, as we learn how our neurological state chemically speaks directly to our digestive tract, are we on the verge of entirely new ways to heal? The GI tract is so much more than just a digestive tube. It's a highly sensitive, interconnected organ system, and the more we understand it, the closer we get to transforming that 11 to 21% of suffering into widespread relief. Thanks so much for joining me on this explainer, and keep exploring.